Welcome to this week's Echo Diabetes in a Time of COVID-19 webinar session. I'm Dr. Nick Cuttress, Program Director and Pediatric Endocrinologist at Stanford University. Good morning, good afternoon, good evening, depending where you're joining us from. Thank you for being a champion for people living with diabetes. We're grateful for the unrestricted educational grants that we received from Novo Nordisk and Pfizer Inc. that make this program possible. Our goal is to address the urgent needs of patients with type 1 and type 2 diabetes who require complex diabetes treatment in the time of COVID-19 and beyond. We want to empower primary care providers and clinics to safely and effectively manage underserved patients who do not have access to routine specialty diabetes care. Even before COVID-19 pandemic, outcomes for patients with diabetes were suboptimal. We must recognize that poor outcomes for people with diabetes on a population level does not reflect patient, quote, non-compliance, but rather system failure. And we as providers in a health system must change our approach to focusing on diabetes outcomes and costs. Data from 191 million people enrolled in health plans that report HEDIS results to the National Committee on Quality Assurance illustrates system failure for patients with diabetes. In 2018, less than 1/3 of patients with type 1 and type 2 diabetes had A1C values at target or less than 7%. Even more concerning, as demonstrated here on this slide, 30 to 40% of patients with type 1 and type 2 diabetes had A1C values greater than 9%. Minimizing hyperglycemia is paramount to reducing diabetes patient risks and vulnerability to infection and complications, including COVID-19. Now is an opportune time to overcome therapeutic inertia and make meaningful system changes so that patients are being able to achieve glycemic targets. We are living in unprecedented times with COVID-19, but systemic racism and health inequalities have been endemic to the U.S. COVID-19 is making these injustices more clear. We must come together as a medical community and change our practice. We must act. When the mortality rate from COVID-19 in Black Americans is at least twice, if not 5 times as high as the mortality rate from whites, we must act. When marked racial disparities in diabetes management exists, and prior to COVID-19, we must act. When Black Americans with diabetes with equivalent socioeconomic status as white Americans are less likely to be prescribed intensive insulin management regimens, newer medications, diabetes technologies proven to improve diabetes outcomes, we must act. We must act and recognize systemic racism and implicit bias that are also occurring within our medical community and practice today. Our leadership team and faculty are committed to promoting health equity through our program and combating systemic racism in the U.S. We're committed to action. Here at Stanford, we're partnering with Project Echo and other sites across the United States on this series. Project Echo is a globally recognized hub and spoke outreach model developed at the University of New Mexico to reduce disparities and improve health outcomes in patients who otherwise lack routine specialty care. Zoom-based clinics led by multidisciplinary faculty from academic medical centers and community organizations provide community providers with education, case-based learning, and expertise they need to treat patients within their own community. We have an exciting series of presentations, all of which made available on-demand sessions after their live presentation. You can access these on-demand sessions on our website, diabetescovid.stanford.edu. You can also access information on our live webinars, patient and provider diabetes and COVID resources, and soon to come an FAQ with answers to questions asked during the webinars, as well as the questions submitted during the live webinar registration process. For our on-demand session, we'll address the high-impact follow-up questions from our last session, a lecture, and we will then address pre-submitted questions from an audience member, submitting questions during the registration for our live webinar. Our case presentations are not available for the on-demand webinar. We're fortunate to have a national faculty from over 12 ECHO programs and organizations around the country. Follow-up from last week's high-impact follow-up question. One of the questions came up, what do we do as providers if we cannot get insurance to approve a personal continuous glucose monitor? What about professional CGM? And Rehan Lal is going to prepare the answer for us. Rehan?
Hey there, guys. So I just wanted to talk about professional CGMs here real quick. Medtronic still makes the iPro 2, which was initially FDA approved back in 2011. This is sort of for historical note. This was a 6 to 7 day professional CGM, cost several hundred US for the sensor and recorder. You would get masked 5-minute sensor values, meaning only the physician could see them retrospectively, uses CareLink iPro software, requires at least one calibration every 12 hours recorded by the patient on either paper or through the phone app called iPro 2 MyLog, has to be cleaned and disinfected between uses. This is the recorder bit of it, the sensor is replaced. In terms of data supporting its use, there was a study in type 2s in India with A1Cs in the 8 to 10% range, which found a significant A1C decrease. And then also a sub-analysis in children with type 1 showed that those with an A1C coming in greater than 7.5% were able to get a significant decrease. And this is with retrospective review by a healthcare provider looking at the data. And Nick, next slide. And so now we move on to the more modern Pro CGM devices. The Freestyle Libre Pro was FDA approved back in September of 2016. It's a 14-day professional CGM. The sensor costs $60. The receiver costs $65. You only need one receiver, and you can use it with as many sensors as you want. This delivers masked values, but every 15 minutes because the storage capacity is not quite as large as some other devices. And you can use it with LibreView or Freestyle Libre Pro desktop software. This one does not require any calibrations, and it is disposable with the reusable receiver. There are a lot of studies looking at the accuracy of this device, but not a ton looking at the efficacy of retrospective review of masked CGM data. And that's been sort of consistent with these devices is the mask data doesn't seem to be as good as somebody who is looking at their data live. And Nick, next slide. So this is the newest kit on the block, the Dexcom G6 Pro. This was FDA approved just last October, which feels like a long time ago, but that is a 10-day professional CGM, costs $59 for the sensor transmitter pair. So you can see that that actually might be more affordable than the $10 per day charge for the home use device, and that's just for sensor cost. And interestingly, this is the only one that can be used masked or unmasked, meaning the patient can see their sensor values and generate it every 5 minutes. You can use the G6 app for the patient, and the provider can use Clarity, obviously no calibrations. This is disposable sensor and transmitter, and it starts the second the transmitter is put onto the sensor. So this one we have a lot more evidence for, because certainly there are G6 studies showing accuracy and utility in the unmasked mode. So this is a whole different ball game than previous just retrospectively reviewed professional use CGMs. And next slide, Nick. So now sort of giving an overview, in the upper right-hand corner, you can see the first CGM I ever wore. That was the professional use Medtronic CGMS back in '99. And this was just a 3-day device, so there have been tremendous improvements since that time. It soon became apparent that for maximum benefit from CGM, the person with diabetes had to look and act on the data. Retrospective review, however, with professional use devices is probably helpful for those coming in with a higher A1C at baseline, and for those where you don't have accurate data using other methodologies. So maybe you don't have all the finger sticks, and it would be helpful to know what's happening overnight, or at times where you don't have data. Can be very effective in those cases. But the G6 Pro is unique among professional CGMs in offering users a straightforward ability to view their data. Home use sensors are $10 per day, so it's about $100 a sensor for a 10-day wear, so $300 in a month, versus the pro use one is a little bit cheaper. And assuming that you feel comfortable ordering multiples of these, it certainly is an option to give users the best of both worlds, and you get reimbursed for every read, so maybe economically feasible. And that's it.
Thank you. Thank you so much, Rehan. And for follow-up questions on the professional CGMs or questions about the personal CGMs, please go ahead and type your questions into the Q&A box, and we will respond to them throughout this, this webinar. So now we're going to move on to our didactic lecture portion of the webinar, and it's my pleasure to introduce today's speaker, Dr. Korey Hood, who I've had the pleasure of collaborating with here at Stanford, and who's also a faculty member on our California-based Echo Diabetes program. Dr. Hood aims to promote health and quality of life outcomes for people living with diabetes. As a psychologist and a clinical researcher, there are two content threads for his work. First, construct prevention and treatment programs to address modifiable psychological and family factors that create barriers to optimal diabetes management. And second, to optimize the use of device technologies to improve health outcomes. Dr. Hood's team at Stanford created diabeteswise.org and carries out clinical and research protocols underway at adult and pediatric clinics. Dr. Hood is the chair of the American Diabetes Association Behavioral Medicine and Psychology Interest Group and a member of the Research Policy Committee. Dr. Hood is presently associate editor for both Diabetes Care and Pediatric Diabetes. Dr. Hood and his research team have published over 135 scientific articles on the topics and are active presenters at diabetes, behavioral medicine, and advocacy conferences. Korey, thank you so much for joining us, and it's a pleasure to have you share your wealth of knowledge with us. We are going to have Korey share his screen. If we have any technical difficulties, we will take over. Go ahead, Korey.
Great, thanks so much. Thanks for the introduction and thanks for the opportunity to speak about this topic. I'm eager to dive right in. So I'll share my screen and hopefully that's clear to everyone. I've got a side message up in case any kind of technical issues come up, and then we can move from there. This topic, diabetes distress and coping in the time of COVID, is I think is really relevant and is probably one that's been slightly overlooked at times, given all that's been going on in the world and all that's been going on specifically with COVID. So I want to highlight a few different pieces here, and as we move through this, I'll highlight some points. Here are my disclosures. I don't think any of those present any kind of conflicts. What I hope you leave this presentation with are a few main points. The first one is really kind of the foundational part of understanding why someone may feel distressed or depressed or stressed about having diabetes. We know that people with diabetes, it's type 1, type 2, all type diabetes, are at elevated risk for depression and distress. And I'll highlight a few points as we're going through this. People with diabetes are not necessarily at higher risk for COVID, but it's really clear from data over these last 4 to 5 months that having diabetes, having COVID adds morbidity and mortality. And so for those reasons, people with diabetes are appropriately worried about COVID, about getting COVID, and then what might happen if they do. So this adds an additional layer of stress and depression to people with diabetes. I'd like to show this image just to highlight what I think is going on in the person with diabetes mind about diabetes, health, all the things that are going on. One of the things just one second, just pausing my video. It looks like there's a little bit of a lag. But one of the things that I always forget to highlight at the beginning when I introduce myself is that I also have diabetes. And so when I think about my thoughts, as well as all of the data that we understand about people with diabetes, certainly there's a lot going on in their mind about the mental and physical aspects of their health. And if this isn't a nearly hourly event, it's certainly on a daily basis, people are thinking about this. And then they have to make meaning of what diabetes is, what it means to have a chronic disease, how to take care of it. And then obviously people are engaging in a number of things to take care of their diabetes. So a number of behaviors on a multiple times daily basis. And when you think about the foundational aspects of having diabetes, many individuals have to get their insulin or get some kind of medication if it's not insulin yet. And then they have to know their glucose. And so just at the very basic foundational level of behaviors, you have new things that you have to do. And then when you think about someone who may have some access to advanced tools around technology, certainly insulin pumps, we've heard a lot about CGM during this series, and then thinking about the integration of these together as closed loop. The main reason to highlight this here is that all of these variables, all these behaviors, all these things that have to be done really create fertile ground for someone to feel distressed or depressed about having diabetes. So what are the most common worries for people with diabetes? What are the things that they tell us as diabetes care providers that they're worried about? I would imagine, as many in the audience today, as diabetes care providers or people with diabetes, thinking about these things, that they likely resonate with them. There may be fear of hypoglycemia, wondering if devices are going to work. Can you trust them? Are they going to be reliable? Am I going to be able to afford it? Am I going to have access to it? Certainly, some individuals have fear of needles or of having to do injections for themselves. The social embarrassment side can also cause someone to feel isolated or guilty in different situations if they're embarrassed about showing that they have diabetes. There are a lot of different situations where there can be interference with daily life, and people can have both those interferences as well as worries about it happening again. And then certainly anxiety about complications, that both the potential development of them as well as when they happen, how to adjust to them. And then we worry about, dependence or being an additional burden on our families. And then, for individuals who are, this is largely relevant to people with type 2 diabetes who have a progression. There's a psychological, to some extent, resistance to taking insulin, because for many people it may mean that they've failed, or at least that's the idea that's been relayed to them. And so these are the common worries, and again, create this fertile ground for people to feel distressed and potentially depressed. So what do the data tell us about depression and distress? And there have been a number of reports over the last couple of decades that suggest that depression and diabetes and stress are very common, and may be as high as there may be a 2 to 3-fold increase in people with diabetes. So compared to people without diabetes, 2 to 3 times the rates of depression and diabetes and stress. This work has really been, if you want to dive a little bit deeper into it, individuals who have done a lot of work in this area in the US are Polanski and Fisher and Hessler in California and Gonzalez in the New York area, and then also around the world, James Spade in Australia, Frank Snook in the Netherlands, Norbert Hermans in Germany. These are all individuals that if you search and look a little bit more, if you're interested in some more local or regional findings in these areas, but generally we see a pretty substantial increase in risk. And then we also know that there's a high point prevalence. So at any given time, you may have 30 to 40% of people in your practice or in individuals that you're working with in other ways. And there's an even higher lifetime prevalence. And we know that when individuals develop something like depression, this is more generally, they're much more likely to have future episodes of it. And we know that diabetes distress in particular, because it's related to diabetes, has a stronger link with poorer management and poorer health outcomes than depression does. So they're both concerning, but concerning for different reasons. And this image highlights a little bit of what we've been talking about so far, but I want to note that it's not always the diabetes that starts or initiates or exacerbates what could be depression or distress, that it's also the case that many individuals who start with depression and distress may develop diabetes. There's some bidirectional links here, and you can see part of the reason is if you look across both of these images that there's plenty of overlap in terms of what someone might be experiencing with depression and or distress, and then also with diabetes, and that and this is part of the problem for when we try and understand how someone is feeling in terms of distress or depression, why sometimes it's a little bit tough to figure out what the symptoms are, because sometimes it just seems like it's part of diabetes and factors related to that, which is why we recommend, and certainly what we do here at Stanford, and then also what is recommended by the American Diabetes Association, is to screen routinely for something like diabetes distress. And so what I've noted here is an article by Fisher and colleagues about using a tool called the Diabetes Distress Scale, and I'll give you a little bit more information on that as we go along. But this is a really helpful objective tool, and you can do it in as short as 2 items, 2 questions, and then if there are positive responses to it in terms of maybe elevated distress, then you can administer more questions. But the entirety of this diabetes distress scale is only 17 items and can complete it in usually under 5 minutes. And one of the reasons that I think it's so important to do this kind of psychosocial screening and specifically to focus on distress and depression is that we know that these can be solid targets for intervention, and from the behavioral side, we can work to reduce this so that people feel more engaged and feel like they're better able to engage with different aspects of diabetes management. And the ultimate goal of any kind of screening is to improve management, improve the way that someone feels so that they can have improved health outcomes. And you'll see here the link at the bottom for the Diabetes Distress Scale. This is from the Behavioral Diabetes Institute. And if you click on that link, you'll see that there are over 30 translations into different languages that you can use with a diabetes distress scale. So it's and it's free and widely used around the world. And you can see here, this image just quickly highlights some of the ways that we've built our screening alert system. And this is even more important now in the COVID era, where potentially we're doing everything remotely, where someone can complete a survey and then as you move around to the right in this image, you can see that they we can get immediate feedback to a diabetes care provider, and then that diabetes care provider can link the person to resources or can follow up directly. And one of the things that we think is really important is it's not enough to just identify people who have distress or depression. You have to offer them resources and then follow up to make sure that they've engaged with those resources, which is there's a big drop off in people and uptake of the resources that are offered. But let me tell you a little bit about what we understand from the psychological impact of COVID. And so I'm going to start more broadly here. This is not specific to people with diabetes, but we'll work our way there. This paper, all of these papers that I'm talking about now are still as preprints or just have just come out online. One of the first studies about anxiety and depression and distress during the COVID pandemic is from Germany. And in this study, I believe that there were about 15,000 individuals that took part of this survey. And what they found was about 2/3 of them indicated a high level of psychological distress. And 50 to 60% were indicating a high level of worry about COVID and about directly getting COVID. And so now, again, this isn't specific to people with diabetes, but there are people with diabetes that would have answered this survey. But this is, when you see something like this on the population level, where as many as 2/3 of people are extremely stressed about the potential for something happening, you know that it is likely even exacerbated more in people with diabetes. One of the other things that I think is noteworthy is that this isn't just about adults, and we see that the impact of social isolation and loneliness has a negative effect on mental health of kids and adolescents, and the lower publication there represents that. And a couple of other things to just note here. We know that it's important to go beyond the virus. This paper talks about some of the additional services that are necessary, and mental health is certainly part of that. And then the last thing I want to note here is how much something like a quarantine or isolation can impact an individual's psychological health. And there's plenty of data coming out of China and Italy and other areas that these kind of mandatory quarantines, while they were absolutely necessary, they also had psychological consequences where many people felt even more stressed and even depressed, and there was a higher rate of suicidal ideation in some of the individuals as well. So what does that tell us for people with diabetes? The likelihood is that they're going to experience a very similar, very high rate of distress, and it's going to even be exacerbated in COVID. So a couple of strategies, I think, as diabetes care providers that we can help our individuals with diabetes, we can help them with. This first point is, obviously, all of us are working in different ways to manage COVID and hopefully to get rid of it. I think it's important to convey some level of hope that things will return to normal to people with diabetes. Even though if we're not sure that time frame, it is important that is stated to them. I think we have to provide support in various ways, and I'll highlight this a little bit more. But listening, asking questions about levels of distress, not immediately going to problem solving for people, but sometimes just listening to some of their worries and concerns about it, and then trying to understand if there are ways that we can be helpful. I think the other part is process versus outcome. I think now more than any other time, focusing on the behaviors and the process of taking care of diabetes is more important than focusing on any kind of outcome that the individual might achieve. So praising them, talking to them about how well they're doing with checking, taking medication, taking insulin, those are the really critical parts versus whether or not they've achieved a certain level of A1C. It's particularly important now. I think if there are opportunities for people to change routines, that can help if there are periods of isolation, periods where they can't, aren't as mobile or can't go as many places as they'd like to. And then I also think that helping them find ways to be advocates or to provide some service, I think that getting outside of themselves can be something that is helpful to them to prevent distress, particularly at this time. And then I think from again, as a diabetes care provider, thinking a little bit about ways to distinguish between burnout or diabetes distress and depression. I think that's something that we can help with. And part of the way that we do that is just understanding how long symptoms have lasted and how closely connected they are to diabetes. When there are opportunities or when there's a need for support, certainly pushing people to support professionally sooner than later. If there's any kind of concern, I think that it makes sense to do this sooner than later. And then also thinking about both for the individual with diabetes, helping them to understand what are some ways that they can personally feel supported within their families, within their kind of bubbles or their units that they're part of, as well as any other kind of remote ways. And I also think that this is important for diabetes care providers as well. We do know that all of us are much better at helping others when we've done something to help ourselves. And so I think that for you as a diabetes care provider, finding ways to feel supported either through your community or through other kind of professional work opportunities, I think can be really helpful. One of the things that we also pay attention to and is thinking about any kind of technology specific burnout. Are there any things that people are experiencing now because they can't change a routine or they can't change, they don't have as quick of access to some of the resources. And so again, thinking about, in this last point about service and advocacy, trying to help them find ways to be an advocate or to empower them in different ways. So most of the evidence for the types of interventions that work well focus on problem solving, helping people understand that what the problem is, and then what are potential solutions, then implementing a plan. And this focuses again very much on a cognitive behavioral framework as well, where there's an emphasis on behaviors and in helping individuals fight distress and depression. There's really mixed evidence for medication for distress, specifically thinking about diabetes distress, but there's really good evidence for medications, the antidepressants for depression and extreme or high levels of psychological distress. And so these are certainly areas of consideration. I want to just highlight for just a couple minutes about why I think that at this time around both distress or around in the COVID era as well as in distress, why technology can be something that can be helpful. This is this image, I'll just quickly highlight one piece down at the bottom. And people were asked, and this is specific to the US, but you would find similar, you would have similar findings around the world where what's made the biggest improvement to life in the past 50 years, and you can see overwhelmingly people talked about technology, the lowest bar there. And when people are asked about what their expectations for how their lives might improve in the future, they talk about medicine and health and technology as the main areas. And so I think that as diabetes care providers, particularly now, we can use some of these things to our advantage to help people. If there's some way that we can improve or increase their access to these different tools, this may also be something that can buffer against some of the distress and depression that's likely to happen at this time. And this also cuts across, and this is again specific to the US, but I think is relevant around the world when you think about individuals from minority, cultural, or racial, ethnic groups, they're also similarly relying on technology for health information. And so this is the main one to look at here is the lowest bar. And you can see across Latinos, Black or African Americans, and whites, you can see that there's a very similar trend that these are some of the most important things that they do with smartphones. And so we have an opportunity, I think, to reduce the stress and to address some of these areas through these smartphones and other aspects or other types of technology that we can use. And I just want to quickly highlight, I think there's plenty of evidence. I'm not going to go into a lot of detail on here. We've heard a lot about this in the series, but certainly these devices, CGM, pumps, insulin pens, they all also have a psychological benefit many times as well. And so as we're thinking about ways that we can potentially help people at a very difficult time, we can also work to be advocates for greater access for these different tools, because we know that they can also have a benefit on the psychological side. Just a few different resources here. I think that as these slides are available, I would check these out. There's certainly great resources about mental health during COVID at both Diatribe and Beyond Type 1. And the Beyond Type 1 wouldn't be specific to just people with type 1, but that's where those recommendations are housed. I already mentioned the Behavioral Diabetes Institute. I think that this is a great organization. And this is also where the diabetes distress scale is. It's, again, free, translated into about 30 different languages, and also has guidance for scoring and interpreting in it. I think one of the really great resources for healthcare providers in trying to understand ways that they can help individuals with diabetes distress is through the Australian Centre for Behavioural Research and Diabetes. And you can see the link there, as well as the National Diabetes Service Scheme, which is produced by a group in Australia. These are really good resources. One that we've talked about on here before is diabeteswise.org. This is a project that we've created at Stanford around devices and access. Also has wisdom and stories from individuals who have experienced distress and frustrations and ways that they've overcome it. This work has been funded by the Helmsley Charitable Trust. And as I mentioned, there are plenty of resources on here about people, unwanted attention due to diabetes. Whether they can have an easy time using it, how they can avoid lows, whatever their priorities are, concerns are, they can kind of tailor their experience to that. We also do quite a bit of work for people to compare different CGMs. And you heard just a little while ago, Dr. Lal talking about the different resources, and if there are ways that we can engage people and push them toward greater awareness of these different tools. That's one of the aims that we have here. And again, this is a free, unbranded website. So to wrap up, and I know I've highlighted a lot of information and thrown quite a few things at you in the audience, but I want to just come back to the take-home messages. At baseline, at the foundation of having diabetes, people are at elevated risk for depression and distress. And that while their risk for COVID may not necessarily be higher simply because they have diabetes, in the presence of both diabetes and COVID, there's there are issues around morbidity and mortality, which are very concerning. And so it's appropriate for people with diabetes to be worried about it, and as you as a provider to be worried about the people with diabetes, certainly in this era. And the main point is that it's likely through all that's going on, whether it's the fear of COVID, whether it's the isolation, whether it's loneliness, whether it's a disconnect from the social connectedness that they had before, that they're going to likely have higher rates of distress and depression. So in summary, I want to highlight that I think it's really important for us to listen to people with diabetes, to listen to their fears and concerns. And we do that by asking them. And this can be a short question, short set of questions that we ask them, or we can use some surveys that are objective. And then we validate them. Diabetes care providers and healthcare providers in general are viewed as having pretty powerful voices for people. And so when you validate them, that can go a long way. So to say, that makes sense to be worried about having diabetes and catching COVID. Those things can go quite a long way to help the person. And I would say to link them with services sooner than later. Don't wait. And I think that if there are opportunities to help them find ways to get social support remotely, those could be really critical tools. And then the last point is to be there for them, to be accessible, to provide support, to provide the guidance they need around diabetes, but to also validate their concerns and worries that they might have. And I'll stop there and thank you for your attention.
Thanks so much, Korey. And we're going to open it up to questions. If you have a question, please go ahead and type it into the Q&A. One question that came up that I'll bring to you, Korey, was I'd like to hear your suggestion in managing diabetes distress in the pediatric population. And just, as a practicing, just to preface it, as a practicing, pediatric endocrinologist, it's all, often people can feel frustrated if you look at just A1C outcomes. And just for a reminder for those of people who are not familiar with the data, this is looking at a mean A1C by age throughout the lifespan. And you have one graph on the bottom of average A1Cs based on the type 1 diabetes exchange registry data, the kind of the top clinics, and then some other real world data above. And if you see in the pediatric population, that's really when A1Cs are the highest. And maybe there's kind of interaction going on between the healthcare provider and the family that could be a little bit more productive. So do you want to maybe comment a little bit more on diabetes distress and kind of pediatric population?
Yeah, I think it's a good question. I would say that some of the same suggestions I just gave apply, but maybe are emphasized even more, or I would emphasize them even more. I think asking about this distress, any kind of concerns, both on the child or adolescent side as well as the parent side, that asking about distress in every visit, every encounter is really important, and to not delay, especially now, if there are any of those kind of concerns. One of the things that we do know, and I didn't highlight it here, but parents have a high degree of distress when they have kids with diabetes. And what they often do is just kind of try and deal with it on their own, and because they view their kids' mental health as more important than theirs, and so they don't always seek the resources that they need. And so I think that we can do a better job of providing those services for the parents as well.
Great. Any other questions, or faculty, any questions you answered you want to bring up and raise to the group?
There was a question that might help for clarification in the beginning of your presentation, Korey, discussing risk for COVID. And someone was asking whether having diabetes made someone immunocompromised, which would inherently put them at higher risk for COVID.
Well,
yeah.
Maybe.
Go ahead, Korey. Yeah.
Others want to take that. I think that what I want to just clarify, maybe. One point I wanted to clarify was in my take-home messages, I think that at least the data that I've seen don't tell me that people with diabetes have some inherent risk for COVID that others don't have. But what it does mean is that in the presence of COVID, there are a lot of things that can go badly or poorly. And so I think that I think it's justifiable for people with diabetes, for parents, for kids, for adolescents to have some concern about and to be maybe extra cautious about situations versus kind of the general population. But I would also look to Dr. Cuttress and others.
Yes, and thanks for the question. And in the Q&A, we clarified. So as the kind of evidence today, having diabetes alone does not increase your risk to contracting transmission of SARS-CoV-2 and getting COVID. But if someone with diabetes were to get SARS-CoV-2, the potential risk of complications, particularly in the setting of hyperglycemia and other comorbidities that go along with diabetes, there would be increased relative risk for complications. So not to mean that everyone gets complications, but the evidence does support increased risk of complications. So people living with diabetes and family have very valid reasons to be concerned based off what things are coming in.
Nick, I'll just add to that. It does seem to be a disproportionate number of the people who've had diabetes for a longer duration. So, you know, a 10-year-old with type 1 who's been diagnosed for 2 years is probably not very likely to have any increased risk relative to the general population.
All right. So now each week we'll look at submitted questions when you register and try to address them. And one of the questions that came up is, should we have patients come to the clinic for routine visits who have diabetes? So Marissa, do you want to address this?
Yeah, thanks so much. I think this is a great question and something that I've certainly struggled with in my own patient population. Is what do we do for our patients during this time? You know, when we think about COVID-19, the way that I kind of approach this in my own practice is to think about the risks versus the benefits. So certainly, you know, the risks to our patients of bringing them in is that we could be potentially exposing them to this infection. And then there's all the other sort of typical inconveniences of having to go to a doctor's office. Patients have to travel, and depending on how you know, far away they live, that might be significant. There can be financial burdens for patients as far as time away from work and travel costs. And I think that those two things have become a bit magnified for some patients during this time, as many people are out of work and might not have their typical income. There's also struggles with childcare, since so many children were taken out of work. So coming to the doctor's office might be even harder now than it had been pre-COVID. As far as benefits, you know, from a physician standpoint, we like to be able to do a full physical exam on our patient and really see someone and sit down with them and make that connection. There's some, you know, certainly diagnostic benefits of being able to get point of care A1Cs in the office, if that's something that your office offers to patients. And for patients with diabetes who use devices, we can download those devices to get the most up-to-date data on their blood sugars and how they're doing. So those two things I think really need to be balanced. If you could go to the next slide. So, you know, the way that we have approached it is to try and minimize the risks. We are still seeing some patients in person amongst our colleagues in my office, but we're seeing fewer people because we really want to be able to space people out and maintain the CDC guidelines as much as possible. We've encouraged a limitation on who can accompany patients, again, trying to keep fewer people in close proximity. So for pediatric patients, we're still allowing a parent or guardian to accompany them. But for our adult patients, unless there's some, you know, physical or cognitive reason why they need someone else with them, we're encouraging them to come alone, which for some patients is difficult. We're encouraging appointments and trying to minimize walk-ins to our clinic. And we're making sure, of course, that everyone has a mask which we provide for them, and we've educated our staff on proper cleaning between patients. But that being said, we've offered quite a few remote visits, and I would say that for patients with diabetes, the majority are being seen through remote modalities. There are a number of different easy, free options that you can use to offer telemedicine to your patients. So if you do not have something that's integrated within your healthcare system, there are different things that you can use that are available. And in the United States, CMS, which is one of our governing bodies, has really relaxed the restrictions on where patients can be in order to get telemedicine and what kind of software you can use to provide that during this time of COVID. So that has really allowed for telemedicine to expand during this unique and challenging time. I think if patients have devices that need to be uploaded, they can be educated on how to do that. And so if they have a computer and internet connection and the proper cables or cloud technology, they can upload their data, which still allows you as a practitioner to see their blood sugar values. And if they don't have that capability, you can still encourage them to keep a glucose log so that you have something to review with them. And obviously, if you have patients who can go out and are willing to go out and do so, they can get labs ahead of time so that you could still check things like A1C and monitor other things that you think are necessary. Telemedicine really does offer some unique advantages that we don't get from an office visit. You can see patients' home environments. I think we all have had experiences where people are not quite sure what medicines they're taking. Maybe they forget to bring their pills to the office. And so I've had quite a few patients go grab the pill bottle, and I finally know what the actual dose is of the medication that they're taking. Depending on what software you use, you can loop other family members into those visits so that people who are supporting the patient can still be a part of their medical care and be a part of those discussions and maybe offer additional information. We've asked patients if they have blood pressure cuffs to check that at home, to weigh themselves at home. And because of all the cameras that people have now with cell phones and webcams on their computers, there is still a fair number of things that you can get on a physical exam. I've looked at people's injection sites. I've looked at the feet of some of my patients remotely. So even though it's not as good as a full physical exam in the office, I still think that there's a lot that we can do remotely. So really, I think it becomes a balance of risk versus benefit and choosing, what the best option is for your particular patient population. But I think that either traditional in-office visits or remote visits can work during this time.